Good afternoon, all of us, and welcome to this week's presentation on the maternity service agenda. It's 5 minutes after the hour 3, and we have about 20 people on call, so it'll be good to start now. At 3 o'clock, we didn't have enough participants, and so we just had to delay about 5 minutes for others to join in. This week, we'll be looking at hypertensive disorders in pregnancy. This is a high-yield topic, a very important topic. When we did a survey at the start of the maternity service agenda, the records that we have, the analysis of the survey results that were taken, the number one topic that was requested was hypertensive disorders in pregnancy. So it's key and important that we do in this today, evidence-based medicine, data-informed presentations. And so thank you for participating in that survey. Based on your responses, we try to tailor the topic. All of us can learn the very important things that we would want to know as rural health practitioners, both midwives and doctors in maternity and other cadre of health staff who are interested in maternity service delivery. Today, we'll be led by the team from the Upper East Regional Hospital. I say Upper West because I'm based there. Upper East Regional Hospital, Bolgatanga. We have Dr. Justice Okyere, who is a medical officer at the maternity, the obstetrics and gynecology department. And our expert panelist is Dr. Aidan Sanwe, who is the obstetrician gynecology specialist at the Upper East Regional Hospital and doubles as the head of that institution, the medical director of the Upper East Regional Hospital. So today we have a legendary team that will join us, and I'm sure we would learn a lot from them. Because of the uniqueness of this presentation and the fact that there's a lot to cover, we have over 80 slides. So, and in keeping with our time schedule for the presentations, we want to make it more interactive. We want to make it something that is of benefit to everyone and something that you be able to remember. So is to divide the presentation into two, so that then we'll do the first half this week, and then next week we'll do the second half of it. And so kindly bear with us. We'll take the first part this week, and then for about 30 minutes, and then we have a discussion afterwards, like we usually do. And then next week we'll look at the core of it. So today is like laying the foundation for the management itself. Without wasting much time, I would want you to join me in welcoming Dr. Justice Okyere. A few housekeeping issues. I would mute all of us, and then if you try unmuting yourself, you realize you'll not be able to, apart from Dr. Justice and Dr. Aidan. And so kindly make use of the chat box if you have a pressing question that you are likely to forget about it at the end of the presentation, so that then we don't get distracted. Thank you so much for joining us for today. Dr. Justice, please start. Thank you very much.
Thank you very much, Dr. Dominic. Good afternoon once again. So I'm Dr. Justice Preston Okyere. I'll be taking us through hypertensive disorders in pregnancy. Okay, shall we begin? Okay, so these are my references. Okay, so there's the outline. So the outline, we look at introduction, the types of hypertensive disorders in pregnancy, diagnosis, risk factors, etiopathogenesis, prevention, and then treatment. But like Dr. Dominic said, we will deal with the first part, the first 3 parts today, and then God willing, next week we'll consider the risk factors and then delve into the management profile. Okay, so by way of introduction, hypertensive disorders occur in about 6 to 8% of all pregnancies worldwide. Populations in the sub-Saharan Africa have experienced a surge in hypertensive disorders in pregnancy over the past 2 decades, partly due to many risk factors that are prevalent in the region. Preeclampsia is the leading cause of morbidity and mortality globally, particularly in the sub-Saharan Africa. Data from the Ghana Maternal Health Survey in 2017 demonstrate that maternal deaths account for about 14% of all deaths in Ghana. So in Ghana, preeclampsia is the second leading cause of maternal mortality at 14.3%, only next to BPH, that causes 29.7% of maternal deaths. So preeclampsia causes a lot of morbidity and mortality, as we stated, not just in the mother, but in the newborns. It increases the rate of stillbirths, preterm births, and early neonatal deaths. And for the mothers, those that survive through the ordeal end up with long-term complications such as cardiovascular disease, chronic disease, chronic kidney disease, etc. The clinical course of preeclampsia is progressive. And usually pharmacotherapy, medications that we give to the patient, does not prevent the disease from progressing. So it is characterized by continuous deterioration that is ultimately stopped only by delivery or termination of the pregnancy. So early detection and appropriate management of pregnancy complicated by preeclampsia does improve outcomes for both the mother and then the baby. So preeclampsia is not simply hypertension arising in pregnancy, but it's a disorder that can affect virtually every organ system in the body. The hypertension bits represent just one facet of the complex disease. So as you said, it's a multisystemic dysfunction that results in generalized endothelial disruption. It is reflected in the various organ systems, the hematological system, renal system, hepatic and cerebral systems. Those are the main principal organs that are affected in the disease pathology. So this review summarizes the current understanding of the etiology, pathophysiology, and clinical management of pregnancies that are complicated by hypertension. We'll be focusing more on the syndrome of preeclampsia and eclampsia. Okay, so these are the hypertensive disorders in pregnancy, the major ones. The first four are chronic hypertension of any etiology. You have gestational hypertension, preeclampsia and eclampsia syndrome, and you have preeclampsia superimposed on chronic hypertension. And then the last entity is HELLP syndrome, which some authors believe to be a variant of preeclampsia and eclampsia syndrome. So this organogram details the differences between the various major hypertensive disorders in pregnancy. So for all of them, the pregnant woman must have established hypertension, which is a systolic BP of 140 or more, and diastolic BP of 90 millimeters of mercury or more. And it's important that measurements of this BP are done at least 4 hours apart during the same visit or on 2 different consecutive visits. So when that is established, then the gestational age comes in to make the differential. So before 20 weeks of gestation, if there is no proteinuria, then we consider the patient to have a chronic hypertension. But if the patient has hypertension with a new onset of proteinuria or a rise in blood pressure or maternal organ dysfunction before 20 weeks gestation, is termed as superimposed preeclampsia. For those beyond 20 weeks gestation, if there's no proteinuria in a new onset hypertension, it's termed as gestational hypertension. And those who come after 20 weeks gestation with established hypertension, having one of the following: proteinuria, maternal organ dysfunction, doubling of liver transaminases, pulmonary edema, uteroplacental dysfunction, those ones are classified under preeclampsia. So we take the conditions one after the other and go talk about it a little bit. So the first one is chronic hypertension of any cause. So it's hypertension antedating pregnancy or occurring before 20 weeks of gestation. Or retrospectively, if the pregnancy happens first during pregnancy and persists for more than 12 weeks or more after delivery, then it's termed a chronic hypertension. So the BP criteria are systolic BP of 140 millimeters of mercury or more, or diastolic BP of 90 millimeters of mercury or more, or both. Diagnosis is based on, as we said, at least 2 elevated BP readings that are taken at least 4 hours apart. So in the setting of severe hypertension, where the BP reading is 160 millimeters of mercury systolic and 110 millimeters of mercury diastolic or more, the diagnosis can be confirmed in a shorter interval, which means that you don't need to wait till 4 hours before you check the BP again to confirm, because you need to facilitate timely intervention to help the patient and the mother and then the baby. So the hypertension, the chronic hypertension can be primary, which is essential hypertension, or it could be from any other secondary hypertension. So these are as follows. You have renal disease, people with parenchymal disease and renal artery stenosis, pheochromocytoma, hyperthyroidism, Crohn's disease, Cushing's disease, obstructive sleep apnea, raised intracranial pressure, certain drugs like steroids and SGs are all known to be secondary causes of hypertension in pregnancy. Okay, so gestational hypertension. So new onset systolic BP of 140 millimeters of mercury or more, or diastolic BP of greater than or equal to 90 millimeters of mercury, or both on at least 2 occasions, at least 4 hours apart after 20 weeks gestation in a previously normotensive woman who has no proteinuria and without severe features of preeclampsia, which are the severe features are thrombocytopenia, renal insufficiency, elevated liver transaminases, pulmonary edema, cerebral or visual symptoms. So these patients are otherwise asymptomatic with normal laboratory panel. However, it is known that about 50% of these women subsequently go on to develop the preeclampsia syndrome. Some researchers have labeled the condition as a transient hypertension if evidence of preeclampsia does not develop and the blood pressure returns to normal by 12 weeks postpartum. So there are a few category of patients that show erratic BP readings. And then we've coined terms for them. So those who show hypertension only at the OPD level or when they visit the hospital, but then at the home setting or outside the hospital setting, their BPs are really normal. They are termed under having quite good hypertension. And then the reverse is also known as masked hypertension. These patients, normally when they come to the hospital with their readings, you realize that the BPs are very fine, but at home or elsewhere, the BPs are high. So for such patients, you need a 24-hour ambulatory BP monitoring to be able to pick up the hypertensive disorder. So a sudden rise in mean arterial pressure later in pregnancy, also known as delta hypertension, may signify pregnancy-induced hypertension, even if the blood pressure is less than 140/90. Next, we look at the preeclampsia syndrome. The definition is a new onset systolic BP of 140 or more, or diastolic BP of 90 or more, or both on at least 2 occasions, at least 4 hours apart, after 20 weeks gestation in a previously normotensive woman, or a systolic BP of 160 or more, or diastolic BP of 110 or more, or both, confirmed within minutes to facilitate timely antihypertensive therapy. That's those two, either of those two, and proteinuria, which is greater than or equal to 300 milligrams per 24-hour urine collection, or protein creatinine ratio of 0.3 or more, or a urine dipstick reading of +1 or more. Or in the absence of proteinuria, there's a new onset hypertension with any of the following features. 1, thrombocytopenia, platelet count less than 100,000 per microliter, evidence of renal insufficiency. So the serum creatinine level is greater than 1.1 milligram per deciliter or 90 millimole per liter, or a doubling of serum creatinine in the absence of renal disease. What this means is if the patient came to you at booking and then you check the renal function, and let's assume that the renal function, the creatinine happens to be 0.4. And then after 20 weeks gestation, you check the renal function again, and the creatinine has risen up to 0.8. So even though it's not more than 1.1, you still consider such a patient as having renal insufficiency. And that's in addition to the hypertensive profile, qualifies the patient to be considered as having a preeclampsia. So the next one is impaired liver function, which is indicated by elevated liver transaminases, which should be at least 2 times the upper limit of normal values. The next on the list is pulmonary edema and then persistent cerebral or visual symptoms. So now proteinuria is not the simple non to characterize preeclampsia as previously postulated. Previously, you need to have hypertension with proteinuria for us to say that you have preeclampsia. But according to the concept proposed by International Society for Studies and Gestational Hypertension, published in 2014 and reinforced in 2018, every hypertensive woman should be investigated for multiple organ involvement, even if the woman has no proteinuria. This approach is innovative and tends to encompass cases that are neglected due to absence of proteinuria, the so-called atypical preeclampsia. So the new classification of preeclampsia is as follows. So at present, we classify preeclampsia as preeclampsia with severe features and preeclampsia without severe features. The severe features could be symptoms, physical examination findings, laboratory findings, and imaging studies. So preeclampsia with severe features. So any of these findings in a patient with preeclampsia, if the patient has a systolic BP of 160 millimeters of mercury or more, or a diastolic BP of greater than or equal to 110 millimeters of mercury, like I said, on at least 2 occasions, at least 4 hours apart, unless the patient is on antihypertensive therapy that is initiated before the 4-hour period, or the patient has a persistent cerebral or visual symptoms, or there's an impaired liver function caused evidenced by raised liver transaminase levels of at least twice the upper limits of normal. When the patient has severe persistent right upper quadrant pain, with gastric pain unresponsive to medication, and not aroused by or accounted for by any alternative diagnosis or both. The next is the patient with progressive renal insufficiency, to explain this earlier, and then whether or not the patient has thrombocytopenia or there's pulmonary edema. The next on the list is chronic hypertension with superimposed preeclampsia. Any of these findings in the patient with chronic hypertension, a sudden rise in BP, the patient is already having BP, it's at less than 20 weeks gestation, but then there's a sudden rise in BP. If the patient is having chronic hypertension, it's more than 20 weeks gestation, and then there's a sudden rise in BP in a previously well-controlled patient, BP patient. Or there's an escalation of antihypertensive therapy, which means that you need a higher dose of the antihypertensive medication to keep the BP control. Then the patient can be considered as having a superimposed preeclampsia in chronic hypertension. Or there's a new onset of proteinuria, or the patient has had a pre-existing proteinuria, but there's a sudden increase in proteinuria. So these patients are considered as having chronic hypertension with superimposed preeclampsia. It is important to note that patients with pure preeclampsia, the disease pathology happens after 20 weeks. But then those with chronic hypertension with superimposed preeclampsia, you can see these preeclampsia features, severe features, happening a little bit before 20 weeks gestation, and it's often associated with fetal growth restriction. So the caveat here is that the precise diagnosis is often very challenging. So clinicians, nurses, midwives, obstetricians are advised that you order a high index of suspension in order to catch the disease process early and restore, good outcomes for both the mother and then the baby. So chronic hypertension with superimposed preeclampsia with severe features. Like we mentioned, any of these findings in a patient with chronic hypertension with superimposed preeclampsia. So a systolic BP, again, of more than or equal to 160 millimeters of mercury, or diastolic BP of more than or equal to 110 millimeters of mercury, despite an escalation of antihypertensive therapy, or the patient has persistent cerebral or visual symptoms, or liver enzyme derangement, or there's evidence of renal insufficiency, pulmonary edema, or thrombocytopenia. Then we move on to eclampsia. Eclampsia, in any woman with preeclampsia that presents with a convulsion that cannot be attributed to any other cause, is said to have eclampsia. So the definition is the occurrence of a grand mal seizure, which is typically generalized tonic-clonic seizure. It can be focal or multifocal, which cannot be attributed to epilepsy or any other central nervous system disorders. The seizures can happen anytime in pregnancy, during delivery, or after delivery. Please note that some mothers may have normal BPs right after the convulsive period. So the last entity we mentioned was HELP syndrome, which is an acronym for hemolysis, elevated liver enzymes, and low platelets. So hypertension may be present or not, and is often considered as a variant of preeclampsia. Since you are dealing with hypertensive disorders of pregnancy, it's important to establish the diagnosis of hypertension in pregnant women adequately, so that you can accurately assess them, and then you don't have false positive cases, or false negative cases. So for the diagnosis of hypertension in pregnant women, the BP, like we've mentioned, and we keep on repeating, it should be at least 140/90 millimeters of mercury on 2 different occasions, at least 4 to 6 hours apart. Or you have a diastolic BP of 110 millimeters of mercury or more on 1 occasion, or confirmed within 15 minutes interval. Or you have a rise of more than 30 millimeters of mercury in systolic blood pressure over the booking BP, or a rise of more than 15 millimeters of mercury in diastolic blood pressure over the booking BP. So the BP is measured on the right arm. For inpatients, you measure the BP on the right arm with the patient lying on her side at 45 degrees Fowlers. For outpatients, the sitting position is preferred. In either case, the BP should be measured with an appropriate sized cuff, and then the occluded brachial artery should be at the level of the heart. Although controversial, there's a growing consensus that the coroscope phase 4 sound, the muffling sound, rather than the disappearance sound, should be taken for the diastolic reading of the BP. So in normal pregnancy, the blood pressure falls. When you look at the curve of blood pressure throughout pregnancy, you realize that right from pre-pregnancy period, as the pregnancy progresses, the blood pressure starts to fall during the first trimester, and it reaches its lowest base in the second trimester at 24 to 28 weeks. Then it starts gradually rising towards the pre-pregnancy levels, but it doesn't really cross the levels that was there before the patient got pregnant. So a raised BP at booking, as example, before 16 weeks, is essentially due to chronic hypertension. And these patients with chronic hypertension in pregnancy usually have a twofold increased risk in developing gestational diabetes as well. Now, proteinuria, since it remains an objective marker in diagnosing our preeclampsia pathology, it's important that we know what you are doing when we are assessing for proteinuria. So to qualify as proteinuria, significant proteinuria, there should be a 24-hour urinary excretion of greater than 300 milligrams, or you have a urine protein creatinine ratio of at least 0.3, and there should be a persistent 0.3 or 300 milligrams per deciliter, which represents +1 on the dipstick when you do your urine sample. And it's very important that we use a clean catch specimen of urine. And you can do that by using a catheterized sample of urine, or you do a midstream specimen urine collection. And this can be done correctly if you clean the vulva and the vestibule to avoid contamination with vaginal or cervical secretions or blood, as these proteins from elsewhere will give us a false positive result. So this is the grading of the proteinuria. We have +1, +2, +3. So from +1 is the significant proteinuria of 300 milligrams per deciliter, and as it goes. So specific gravity may affect the results that you have. If the urine is too dilute, you end up having a false negative results, and a concentrated urine will give you a higher grade of proteinuria. Please note that proteinuria remain a crucial criterion for diagnosing preeclampsia, but new studies indicate that it has a poor predictive value for determining disease severity. That means that patients can come, like you mentioned earlier, some of the preeclampsia patients will come without proteinuria at all, what was previously known as atypical preeclampsia. So if they come and then they don't have proteinuria, you may not tell. Someone may come with a proteinuria of, let's say, +4, 4 pluses, and may not have severe features associated with the preeclampsia. Someone will also come with no proteinuria at all, but have other evidence of end organ damage, and the person will go on to have severe preeclampsia and eclampsia. So the quantity of proteinuria doesn't predict disease severity. So let's look at risk factors. So to date, the risk factors for hypertensive disorders in pregnancy is not fully understood, but there are various genetic, environmental, nutritional components that are involved. So here we group the risk factors into two broad categories. There's the general risk factors, and then the risk factors that are specific to pregnancy. So for the general risk factors, the extremes of reproductive age, that's less than 20 years, and then more than 35 years advanced maternal age, increases your risk of having preeclampsia. And then Black race is also a risk factor. Patients with diabetes mellitus or gestational diabetes also have increased risk of preeclampsia. Chronic hypertension, chronic renal disease, obesity, antiphospholipid syndrome, and thrombophilia, and then a family history of preeclampsia increases your risk of having preeclampsia. So for the pregnancy-related risk factors, you have nulliparity and then preemie-paternity. A patient who, let's say, was previously having a family with a different man and has gotten married to a new man, the exposure to new semen from the new man can increase a risk for preeclampsia. We'll go into the details later. Having multiple gestation increases your risk. Hypertensive molar pregnancy is a risk factor for preeclampsia. Previous preeclampsia is also another risk for in subsequent preeclampsia development. And those who achieve pregnancy through assisted reproductive technology also have a higher risk of preeclampsia. And there's been evidence that chromosomal abnormalities and other congenital structural abnormalities also contribute to the risk of preeclampsia. So a study by BMJ 2013 looked at the preeclampsia sequence from 1980 to 2010. And it realized that the prevalence of preeclampsia has been increasing on the upward side now. And these are attributed to several factors. Like you mentioned earlier, the use of assisted reproductive technology methods. And now women are getting married and give starting families later in life as compared to, like 2-3 decades ago because of education and career. So by the time they want to start their families, they're already 30 plus, 35, advanced maternal age. And around that same pool, they would have already developed hypertension or diabetes. So they will now become pregnant, and pre-existing medical cardiovascular risk increases your risk of having preeclampsia in pregnancy. Okay, so early diagnosis problems are also responsible for ascending trend of preeclampsia prevalence. So different due to the economy. So like you mentioned, it tailors in with the previous slide that you've mentioned, a decrease in incidence in high income countries because they have access to quality care, quality prenatal care. So women that are predisposed to preeclampsia, there are screening tests and things that can be done to see if they are at risk, and then their risk profile is stratified, and then they are put on correct regimens to ensure that they don't go on to develop full-blown preeclampsia in pregnancy. And also, those that are picked up as having higher risk, like you mentioned, are put on effective management so they don't go on to develop further complications for themselves and then for the baby. And the situation is reversed in the developing countries or low-income countries. So this also explains the previous slide. Okay. All right. So this is according to the American College of Obstetricians and Gynecology, it was adopted in 2019. So this is a table, a box that is summarizing whatever I've discussed in the last few slides. So pathogenesis. So previously, preeclampsia was thought to be primarily ischemic in nature by way of the pathogenesis, affecting the placenta, the kidney, the liver, and then the brain. And this is adapted from the National Institute of Hypertensive Disorders and in 1973. But currently, the current model suggests that there's a growing evidence that it's more of an immune-mediated approach where the cellular immune responses are involved in the pathogenesis of preeclampsia. And the major cellular subsets involved in the pathogenesis are regular T cells, effector T cells, NK cells, monocytes, macrophages, and neutrophils. So currently, we are dealing with the understanding is that preeclampsia is caused by an abnormal maternal immune response to invading trophoblasts of placenta. And this causes defective placentation. It is driven by primiparity, partner chain, like we discussed earlier, and ovum donation for fertility treatment. So the pathogenesis is a bit detailed and it's very bulky. So I'll quickly rush into it and mentioning all the salient points as I can, and then we'll go into the pathophysiology. So by way of explanation, the defective placentation, there's impaired endovascular invasion of the spiral arteries by the trophoblast. And this predates the ischemic reperfusion injury that is typical of preeclampsia. So this is a picture that is showing how preeclampsia develops and all that. So before that, there'll be the immune response that is impaired, and it will cause abnormal placentation. And then there'll be hypoperfusion of the placenta with ischemia of the placenta, resulting in the release of placental factors that will go on to cause the disease pathology. So this is a new hypothesis that is currently, accepted, whether it is the placenta itself that is causing the disease or the placenta is a victim of a disease process. So it was initially thought that the placenta is the primary agent of the primary cause of the disease, but there's no clear evidence for that. Now there's an emerging evidence that preeclampsia is due to secondary placenta dysfunction due to suboptimal maternal cardiovascular performance and immune disorder resulting in uteroplacental hypoperfusion. There's now abundant studies that states that cardiovascular dysfunction precedes the development of preeclampsia by several weeks or months. So this is the key pathogenesis of preeclampsia. So a normal implantation is characterized by extensive remodeling of the spiral arteries within the pseudobasalis. So in women who have a very stabilized immune response, there's a good invasion of the placenta bed into the vascular endothelial tissues and the muscular lining of the endovascular by the endovascular trophoblasts. And this results in an enlargement of the vascular diameter. So this invasion happens in two phases. The first wave occurs at 8 to 10 week gestation, and then the second wave occurs at 14 to 16 week gestation. The purpose of this invasion is to destroy the elastic muscle fiber of the vessels and render them lax and unresponsive to vasoactive substances. So this creates a low resistance blood flow in the placental bed for effective placental perfusion. However, in women that are destined to have preeclampsia, there's a defective formation of this particular process. So the extravenous trophoblast in pregnancy, express is really reduced. And then the reduced amounts of immunosuppression, non-classic human leukocytic antigen gene. And then it's associated with a loss of maternal immune tolerance to paternally derived placental and fetal antigens. So this leads to impaired formation or blocking of maternal antibodies to placenta antigenic sites. So this defective immune response results in an imbalance of antigenic factors, causing disruption and remodeling process that ensures the smooth transition from vascular, endothelial, and muscular linings by endovascular trophoblasts, leading to failure of the enlargement of the vessel diameter. As you can see in the image on the right side, there is a normal invasion that occurs on the left side of the image, which you can see that the vessel diameter over there is wider as compared to the one with the preeclampsia. So the one with the preeclampsia has a narrower vessel diameter. So there's high resistance on that side compared to the normal one, which is very wide, and then there's low resistance for the disease pathology. So it is shown that the one with the preeclampsia, typically the vessel diameter is only reduced by half compared to the one with the normal trophoblastic invasion. Like we said, once the preeclampsia pathology is there, this creates a high resistance blood flow in the placental bed. So in general, the magnitude of defective trophoblastic invasion is thought to correlate with the disease severity of the hypertensive disorder. Okay. So this is also ties into the previous, explanations that we've made. All this goes on to cause widespread endothelial cell changes that is responsible for the disease pathology. So for the endothelial cell damage that happens during the invasion, you end up having a damaged or activated endothelial cell that leads to endothelial leak, or there's a release of lower levels of nitric oxide. Nitric oxide is a vasodilator. So when there's a lower levels of nitric oxide, you end up having a tensile effect on the the vessels at the uteroplacental level, and that increases the tension at that unit, and then it results in the preeclampsia disease pathology. It has been shown that there are several genetic factors that contribute to preeclampsia disorder. So families that are destined for preeclampsia usually have a higher incident risk of having preeclampsia compared to the general populace. So for daughters of mothers who are preeclamptic, they have a 20 to 40% chance. And then preeclamptic women, sisters of preeclamptic women have 11 to 37% chance. And then for twins, the incidence rate is between 22 and 47%. Okay, so in sum, the etiopathogenesis. So essentially, hypertensive disorders in pregnancy are more likely to develop in women with the following characteristics. One, those women who are exposed to chorionic villi for the first time, like you mentioned, nulliparity or paternity. Those who are exposed to abundance of chorionic villi, as with twin gestations or those with adaptive form or molar pregnancy, or patients with pre-existing conditions of endothelial cell activation or inflammation, such as diabetes, renal disease, or cardiovascular disease, and those who are predisposed by genetics to have preeclampsia. Okay, so this is the pathophysiology. So what is the effect of this pathogenesis on the various organ systems? So for the cardiovascular system, there's an increase in afterload caused by the high resistance flow you mentioned in the pathogenesis. And it's very important that these patients are very sensitive to IV crystalloids. So we will talk about that in the management of preeclampsia, hopefully next week, how we should be careful about administering infusions to patients who have preeclampsia. Okay. All right. So there's, like I mentioned, there's a reduced cardiac output due to increased peripheral cardiac resistance. And then hyperdynamic ventricular function is also there, increasing pulmonary wedge pressures. And these ones will lead to pulmonary edema eventually. Also, patients with preeclampsia are known to have hemoconcentration. So when they come to us, because of the contracted volume, they may have a false, the HB may not reflect what is actually happening, because they may come with an HB that is very good. But on paper, if you try and correct the hemoconcentration, you realize that they have lower HBs. So such patients typically are very sensitive to the amount of blood loss at delivery. So what's the normal blood loss during delivery with respect to a pregnant woman and delivery? For the preeclamptic woman, minimal blood loss is very, very significant. You may end up going into BPH. Okay, so the changes we see in the hematological system, there's significant thrombocytopenia. So overt thrombocytopenia that's less than 100,000 per microliter indicates severe disease. So the lower the platelet count, the higher the rate of maternal and fetal morbidity and mortality. In most cases, delivery is advisable because thrombocytopenia, it will continue to worsen. Even after delivery, the platelet count will continue to decline further for the first day or so, and then there's a gradual increase to reach normal levels at between 3 to 5 days. Hemolysis is the feature of the hematological changes seen in preeclampsia. So it's manifested by elevated levels of serum lactate dehydrogenase. And when you do a peripheral blood film, you see spherocytosis, pseudocytosis, reticulocyte, and all these point to the picture of hemolysis. So these result from microangiopathic hemolysis that is caused by the endothelial destruction we talked about. So in the setting of hemolysis with elevated liver enzymes and low platelets, as we discussed, we have HELLP syndrome. So an abnormally elevated liver transaminase levels are indicative of hepatocellular necrosis. And these are included in the criteria that differentiate severe from non-severe preeclampsia. HELLP syndrome could be either complete or partial. The partial one doesn't have all the three derangements. You can have just one or two of the factors involved. Okay, so this is just a picture detailing the HELLP syndrome. Okay, so and fluid and electrolyte changes. So in women with severe preeclampsia, the volume of extracellular fluid that is manifested is increased because of variations in oncotic pressure as compared to those who have normal physiology in pregnancy. So the mechanism responsible for this is pathological fluid retention that is due to the endothelial injury. So like you mentioned, the endothelial injury results in diapedesis of tissues of albumin and other proteins in circulation, sieves through the leakage areas, and then gets into the interstitium, creates a high osmotic pressure gradient, and then the patients come with edema. This is worse. Okay, so that's just about it. And so at the kidney level, in preeclampsia, renal perfusion is decreased by 20% because there's an overall reduction in cardiac output, and the glomerular filtration rate will reduce even further by 30%. So this is manifested by, this may result from reduced plasma volume, but most of the decrement, however, occurs from an increase in the renal afferent arteriolar resistance. So there's less blood flow to the glomerular capsule. So you end up having lower volumes of filtration happening at the glomerular level. So you end up having a fivefold risk of having an oliguria. So in such patients, intensive intravenous fluid therapy is not indicated as treatment because of when you want to correct the oliguria, because rapid fluid infusions may cause clinically apparent pulmonary edema. In normal patients, what you expect from the uric acid is that at the renal tubular level, there is secretion of uric acid into the descending loop of Henle. So it secretes a lot of the uric acid at that level and it's excreted. But however, in patients with preeclampsia, the secretory function is typically disrupted. So you end up having high levels of uric acid in the blood sample long before you see serum creatinine levels rising or even proteinuria rising in preeclampsia. So the serum uric acid levels that are very high levels of serum uric acid is typically an early marker of disease severity. So these are the changes that we see on a microscopic level when you look at the kidney at the glomerular level. So you can see on the picture to your right, you can see the normal endothelial levels of the endothelium here looks very thin, and then the fenestrations are wider compared to the one with the preeclampsia that shows swollen fenestra. The fenestrations are very narrow over there. So all these endothelial swellings and all those fibrin deposits all contribute to the renal pathology that is seen in preeclampsia. So on the liver also suffers when there's a preeclampsia pathology going on. So severe preeclampsia manifests with moderate to severe right upper quadrant pain or mid-epigastric pain or tenderness. So it is secondary to hepatocellular infarction, periportal hemorrhagic necrosis, or hepatic cell edema, causes stretching of the Gleason's capsule combination. Or rarely they could have a liver hematomas. So these damages to the liver end up having elevated liver enzymes and high bilirubin levels. So let's look at the neurological manifestations. So severe preeclampsia may manifest as headache and scutomata and are thought to arise from cerebrovascular hypoperfusion that are separate direction for the occipital lobe, which represent the visual fields of the brain. So 20 to 30% have visual changes preceding the eclamptic convulsions that they have called the aura. So the headaches may be mild to severe and do not usually respond to traditional analgesia, but they do improve after you've given them max surface infusion. So convulsions are a second cause of the pathology. Aside the headache, convulsions are a second manifestation of the pathology, aside the headache and then the scutomata. So convulsions is usually from the excessive release of excitatory neurotransmitters, especially glutamate, causing massive depolarization in the neurons, and then a burst of action potential. So blindness is rare in preeclamptic women alone, but it complicates eclamptic convulsions to up to 15%. It improves with magnesium sulfate therapy or when you lower their blood pressure. It's usually reversible and may arise from 3 areas of the brain: the visual cortex, like you explained, at the occipital lobe, the lateral geniculate nuclei, and then at the retinal level. At the occipital level, the blindness is also known as amaurosis fugax. It's a transient loss of vision that typically happens in the preeclampsia, or more importantly in the eclamptic women after they've had the fits. So it typically lasts between 4 hours to 8 days, but it resolves completely. Rarely, it can have extensive cerebral infarctions that may cause long-standing vision problems. So at the retinal level, it can have blindness from retinal detachments that could lead to blindness, or you could have retinal infarction, which is also known as posture retinopathy. Serious retinal detachment is usually unilateral and seldomly bilateral to cause total vision loss. So generalized cerebral edema may develop and is usually manifested by altered mental status that vary from confusion to coma. And then the edema that results can be fatal, because if it is too much, you end up having a transtenterial herniation that may lead to death. Okay. So how about prediction and prevention? Is there a way that we can predict preeclampsia in pregnant women that come to us? I know these tests are far and in advanced countries, they put some measures in place to screen women that come even before they get pregnant, prenatal visits. They screen them to ensure that um, women that have higher risk of developing preeclampsia are adequately assessed, and effective measures are put in place to control the risk. So the predictive tests here are relating to placental perfusion disorder, the test at the uteroplacental level, renal function at the talar level. So let's look at some of the tests. Vascular resistance test. There's a one provocator test. 3 tests have been extensively evaluated to assess blood pressure rise in response to the stimulus. The first one is rollover test. So here the patient lies down. A pregnant woman within the gestational year of 28 to 32 weeks, you ask them to lie down on their left lateral decubitus position, and then they roll over to the supine position. If there is an increase in blood pressure, then that's a positive test. You can also let them do the same maneuver for isometric exercise. You give them like a squeezing of a handball. So you measure the BP before they squeeze the handball. You record the value. After they are squeezing the handball, you check the BP again. If there's a rise in the BP, then they have a higher risk of developing preeclampsia. And some centers also administer angiotensin 2, which is a latent vasoconstrictor, and then the hypertensive response is quantified in them. There's also uterine artery Doppler velocimetry that can be used to assess whether the woman will go on to develop preeclampsia. So all these are tests that can be done to pick risk factors for women that's going to become preeclamptic. Yeah, so there's a growing body of interesting biomedical markers that can also be used. This include placental growth factors, soluble FSM like tyrosine kinase 1. All these is in advanced countries, hopefully to be able to catch on with that, and then also start screening our women for preeclampsia. By way of prevention, there are several approaches that have been, attempted through randomized control trials to see if they can help controlling the BP profile and controlling the hypertensive disorder in pregnancy. So this includes dietary manipulation, where there's low salt diets. It's advocated for calcium, fish oil supplementation, exercise, cardiovascular drugs, antioxidant therapy, and antithrombotic drugs are also used to see if you can control them. But the most important one here is the use of soluble aspirin. So what you do is that this table details stratifying patients according to whether they are high risk, moderate risk, or low risk. High risk patients, you should have had if they have a previous history of preeclampsia, or they have multifetal gestation, chronic hypertension type 1 or type 2, diabetes, renal disease, or autoimmune disorder. Such patients are high risk, and it's recommended that you start a low dose aspirin for them if the patient has at least one of these. For moderate risk, it's mononeuroparity, increased BMI, family history, poor social demographic data, extremes of maternal age, especially advanced maternal age, personal history, factors, low birth weight, and all that. Those patients are considered moderate risk, and you start low dose aspirin for them if they have at least 2 of these moderate risk factors. But for those with low risk factors, aspirin therapy is not recommended for them. So following the first trimester screening and assessments for preterm preeclampsia, women who are identified as high risk, as you mentioned, should receive aspirin prophylaxis. It is important that you start very early. You start between 11 and 16 weeks, but ideally should be at 11 weeks. So if they come to antenatal centers very early, and before 11 weeks, we can refer them to a higher center where they can be adequately assessed, and then you start the soluble aspirin therapy for them. According to the FIGO criteria, a dose of 150 milligrams should be taken every month until either 36 week gestation or when the preeclampsia is diagnosed. So now the question is, here we are more accustomed to the 75 milligram dosing as compared to the 150 dosing. But according to the American College of Obstetricians and Gynecologists, per recent data in June 2023, they have the 60 milligram aspirin, which they use, but it's said that it's ineffective in preventing preeclampsia. A low dose response effect has been demonstrated between using 60 milligrams and incrementally to 150 milligrams. And then with the currently established optimal dose being more than or equal to 100 milligrams of aspirin. So aspirin preventive treatment, prophylactic treatment, the best results are seen when you give them at least 100 milligrams of aspirin. The maximum beneficial effects of aspirin is observed when you give them 150 milligrams. As of now, there's no trial in developed country that has demonstrated the benefits of using between 80 or even 81 milligrams of aspirin in the prevention of preeclampsia. In fact, a recent meta-analysis, including 4 randomized control trials, suggests that there's a dose of 150 to 162 is superior to giving 75 to 81 milligrams of aspirin for the prevention of preterm preeclampsia by 62%. So we're almost done. So according to the 2019 proposal, women who have maternal a weight of less than 40 should receive 100, which is the optimal dose, and those who have their weights are more than 40 or more should receive 150 dose. Okay. So I think we'll end there. From here going, we are going into the management itself proper. So we'll end here for a discussion, and then God willing next week, we will consider the management profile into detail. Thank you very much.
Thank you very much, Dr. Okyere. This has been excellent and in-depth into the basic sciences regarding hypertensive disorders in pregnancy. I must apologize for those who probably are not into the core of maternity service. This may be in-depth, but I'm sure you'd have learned a thing or two. The meat of the matter will come in when we look at the management, but it must be stressed that understanding the pathophysiology, the pathogenesis, does help in understanding the management and why we use certain medications. I've learned a lot. I'm sure a lot of us have also learned so much. So it's time for questions, for comments, for suggestions. If you have any, kindly electronically raise up your hand. I'll just unmute you and you ask your question, make your suggestion, make your contribution to make this presentation rich. It's a discussion for all of us. So the floor is open, please. Please don't feel shy. If you have something to say, just electronically raise your hand and then I can unmute you to talk. Great. Stacia, please go ahead.
Great presentation. Thank you for that. When I was working with the midwives, we were discussing the balance between giving the low dose aspirin and also kind of weighing the risk of postpartum hemorrhage. But what I didn't know if there was a different pathway because I just don't understand these pathways well enough, if there was a different pathway in postpartum hemorrhage and that the aspirin wouldn't necessarily increase that risk. And I'll mute again.
Excellent. Dr. Okyere, do you have any response to about the risk?
Yes, please.
Benefit? Yeah.
Yes, please. So that's the proposal is we stop the aspirin therapy at 36 weeks gestation when you're anticipating delivery in the next 2 weeks or so. So within that time, the body should have recovered its antiplatelet effects for you to reduce the risk of having a postpartum hemorrhage in the patients. So the timing of stopping of the aspirin is very key here.
Great. I see Dr. Sanwe is on. Dr. Sanwe, do you want to put in a word? Okay, Dr. Sanwe, your microphone is muted. You could just unmute yourself if anytime you're ready. Clifford, you've not connected your microphone, so if you could kindly connect that. I see your hand is up, but I can't unmute you because you've not connected with your microphone. All right. So just from in adult medicine, aspirin back in the day used to be like the wonder drug, and I must agree with you, Stacy. With time, there were issues with regards to there's so many married side effects that can come with prolonged use of the NSAIDs, and so. For us, several trials that usually would look at the benefit versus the adverse effects, and then we usually make proposals. So back in the day, if you look at most old people who are hypertensive, even before start of antihypertensive medications, most people were put on soluble aspirin, and several trials, including the ASCEND trial, which is a hallmark trial in adult medicine, regards the use of aspirin, has shied a bit away from aspirin as primary prophylaxis. The same cannot be said about the preeclampsia and all of that, like Dr. Okyere did mention. But for us, what we usually would keenly talk to patients about regards that is to know the risk, and then what usually to do should you encounter any of the symptoms. So for instance, someone who is put on soluble aspirin for a cardiovascular disease, atherosclerotic cardiovascular disease complication, either prior to stenting or any of that. Typically, we warn them about the risk of bleeding, and then typically to omit the dose when they see any of such, and then reporting to hospital. Also key is for those who are going on long term, usually who will start a PPI, like omeprazole, usually for the side effects of aspirin on the gastrointestinal system, the NSAID-induced gastritis and all of that. I'm not sure same can be said of the OBGY regards the risk versus benefit, but it's clear that for secondary prophylaxis, it is there. I see Dr. Tanwe, sir. Please, Dr. Tanwe, go ahead. You can mute yourself and then talk. Yeah. Hello? Yeah, I think probably its network may be challenging. So definitely, we should be guided as well and explain to the patients, and then as well, like Dr. Okyere mentioned, just at where the risk is higher prior to delivery, you may have to withhold that as well. Stacey, are you okay? I still see your hand up. Is it a legacy hand, or you want to?
I can't. I don't know how to put it down.
Oh, okay, no worries. I'll put it down for you. Yeah. All right. So, Clifford, you can unmute yourself, please. Nanzang Clifford, please unmute yourself. Okay. I think Clifford is finding it difficult to unmute himself. When you are able to, you can go ahead with your contribution. Yeah, so in the chat box, whilst we wait for Clifford to unmute himself, Dr. Salam is saying, good evening, nice presentation. Can clopidogrel be used when aspirin is contraindicated? Example in those with PUD. Dr. Okyere, any response to that? Substituting, what do you call it? Clopidogrel for soluble aspirin.
Yes, so according to the study that they did, they found out that obviously it's not every patient that you can put on soluble aspirin, like those who have worse profiles with, like, let's say, patients with long-standing gastric ulcer, so they prefer the combination of clopidogrel with dipyridamole as against using aspirin and clopidogrel alone.
Great.
So yes, so if the patient doesn't qualify for aspirin therapy and you're using clopidogrel, a combination of that one with dipyridamole is preferred. But then again, it boils down to availability of this drug in the system in our parts here. So that has, a bit of hampered its usage in our setting here, especially with the diaperiodamo. So that's just about it.
Okay, great. Same as well. Usually we would do aspirin in the acute stages, and I usually will convert to clopidogrel, best usually with diaperiodamo if it's available. So Clifford, I guess it's probably a hand in error. Is that so? Otherwise, you can unmute yourself. All right. I don't see any other hand up. Anyone with any question? All right. Dr. Hayden is back. Please go ahead, Dr. Hayden. I've made you a host.
All right. Good afternoon. And sorry, I fell off at the point. My network has been a bit challenging. But overall, I think that Dr. Okyere has done a great job. We sought out to lay a foundation for what is to come, hopefully next week, in terms of the management protocol for hypertension and hypertension-related diseases. We know that it's a major killer, which he has mentioned. If we look at in terms of morbidity nationally, is competing head-on-head with hemorrhage, which we've already done as part of this series of presentations. The bit about the pathophysiology, I'm sure probably at that point I was offline, but I believe that he went through that very well. In terms of the classification, the risk factors, and all those factors, I would not want to reiterate that because I know he would have done a good job on that. So suffice to say that the management principles will be laid out this week, hopefully. There was a question when I rejoined about the aspirin. I didn't quite get that question. If I had that one, probably I would just address that, and then I would say that would be the last word.
Great. I think Stacey wanted to know about the risk versus benefit, use of aspirin, and then the risk of hemorrhage. And I think Dr. Okyere excellently explained what the guidelines are with regards to using it and then usually holding it up just before delivery so that then the risk of hemorrhage will not be that high. And then I did add that even in adult medicine, it's same that we look at the risk versus benefit, and then we appropriately will give soluble aspirin with a couple of the trials that point out to not using it as primary prophylaxis for atherosclerotic cardiovascular diseases. And then I think the second question was still related to soluble aspirin as well, but that one was about for those who are the soluble aspirin is contraindicated, can you use clopidogrel? And then I think the Okyere beautifully answered that as well, that you can. The evidence is more with clopidogrel plus diperidamole rather than clopidogrel alone. So these were the things we made to progress the questions.
Okay, that's fine. So I mean, for the first one, I think that generally we stop it before term, just late preterm, because you don't want the person to go obviously into labor with increased risk of bleeding during the labor process or postpartum. And also the other trick is that you don't really go high dose because, with high dose, you block both pathways, the COX-1 and COX-2 pathways. That's why you use low dose. So you block only COX-2 pathway. So you don't really increase the risk of hemorrhage so much. So basically that would be for the first one. In terms of the contraindication, if aspirin is contraindicated, you can use a clopidogrel or a combination of clopidogrel for that as well. Yes, so probably this will be the points I'd make on this. I think that should be it. So next week, hopefully, we should be able to go into a bit more into the management and what goes into the management.
Okay, excellent. So I think we've done great today. Dr. Okyere did a legendary job. I learned a lot myself. The pathogenesis is usually hard to understand, especially the details with that. I see a couple of the obs and gynae residents have joined as well, and I'm sure that's bread and butter for them. So it's sort of like a reminder to all of us. And so thanks, Dr. Okyere, for this excellent job. Next week, we'll follow up with the management, which I'm sure a lot of people are more interested in, because that is virtually what we do daily at the clinics. Those of us who are not in training or not in school, mostly you would want to know what to use and what not to use. And so let's book it on our calendar that next week we have a date again to learn and have a discussion on the management of hypertensive diseases in pregnancy. So thank you so much for joining us today. A big one to Dr. Okyere and Dr. Samuel for leading us with this presentation. Hopefully, God willing, next week we would have a continuation of that. And I see a lot of people applauding you, Dr. Okyere, that you've done an excellent job. And so thanks a lot for this. Thank you, and God bless all of us. Bye-bye.
Thank you.
Thank you. Great. Thanks to everyone for joining us. Bye.